Assalamu alaikum wa rahmatullahi wa barakatuh. Now this is the fourth and the last part of our discussion regarding the anti-epileptic drugs. In this, we will have a brief discussion about the other important drugs. And lastly, we will touch the aspect of management of status epilepticus. Now, first of all, some important drugs, Lacosamide. So basically this drug was studied for pain condition, but it has been seen quite useful for the partial seizures also. Its mechanism is it enhances the inactivated state of the sodium channel. As far as uses are concerned, as we have seen, a partial seizure, so especially partial onset seizure with or without secondary generalization, especially in young patient up to 16 years of age or even older than that, Lacosamide is useful. As far as the adverse effects are concerned, minor dizziness, headache, nausea, diplopia, etc. Next drug is Vigabatrin. Its S enantiomer is active and it is an irreversible inhibitor of GABA aminotransferase enzyme. That enzyme which is responsible for the degradation of the GABA into its inactive metabolite. At the same time, it may also inhibit the vesicular GABA transporter. So this way, it increases the GABA-like activity. It produces a sustained increase in the GABA concentration in the brain. And remember, due to this increased GABA concentration, there is another change, a secondary decrease in the brain glutamine synthesis activity. So, inhibitory effect is increased, excitatory effect is decreased, but overall result is increased inhibitory effects in the brain with the Vigabatrin. We have observed some desensitization of the synaptic GABA A receptors, those receptors which are at the synapse, but GABA A receptors which are present on other sites, through prolonged activation of those receptors, we have seen inhibition in the tonic activity of the patient. The half-life is approximately up to 8 hours. But as far as the pharmacodynamic activity is concerned, that is much prolonged than the half-life due to some avid binding or prolonged duration of action. Vigabatrin is quite useful in the partial seizure. However, in other types of seizure, it is also very effective. As far as the contraindication is concerned, only if there is pre-existing mental illness, we should not use Vigabatrin. It can aggravate it also. Toxicity, very minor type, drowsiness, dizziness, and in some patient weight gain also. Very less common adverse effects includes agitation, confusion, and even psychosis, but it is very rare. There is some sort of reversible intramyelinic edema in infants especially. However, its clinical significance is still not known. When it is used for longer time, some visual field defects have been observed up to 1/3 of the patients using it. Therefore, Vigabatrin usually is not useful in infantile spasm. Now the next drug is the Lamotrigine. It acts like just ferritin because it produces sodium channel inactivation, and it's quite useful in focal epilepsy. But at the same time, it also inhibits the calcium channels. Due to that reason, it is very useful in primary generalized seizure, especially children, and also useful against the absence attacks in the young children. Third part is that it has also been seen to decrease the release of glutamate at the level of its synapse. So 3 possible mechanisms Lamotrigine have been observed. As far as the uses are concerned, Lamotrigine is quite useful as add-on therapy, but as monotherapy, it has also been seen quite effective for the partial seizure. It is also active against absences and myoclonic seizures, especially in children. Another important thing is that it has been seen that it is quite commonly prescribed for the bipolar disorders. Its adverse effects include dizziness, headache, diplopia, nausea, drowsiness, even hypersensitive reaction, which are related to skin, and potentially life-threatening dermatitis. Exfoliative dermatitis have been seen up to 2% of the patient related to children. Next group is of two drugs, gabapentin and pregabalin. Both are GABA analogs, but they do not act directly on the GABA receptor. Structurally, they resemble to GABA, but practically their behavior is different. Initially, gabapentin was actually determined and useful as a spasmolytic, but later on, it was found to be quite effective as an anti-seizure drug, and it is quite useful against partial seizure. While pregabalin is approved for both anti-seizure activity and for its analgesic properties. As far as the mechanism of action is concerned, the mechanism of both gabapentin and pregabalin, okay, it binds to the calcium channel, especially its subunits alpha 2 delta. So in this way, they decrease the calcium entry. Due to that reason, there is decrease in the synaptic release of glutamate, which is an excitatory neurotransmitter. So in this way, it provides its anti-epileptic activity. Both these drugs also modify the synaptic or the non-synaptic release of GABA. In this way, they increase the concentration of GABA in the brain. As far as uses are concerned, gabapentin is effective as an adjunct against partial seizure. However, we have tried it as a monotherapy also. In very high dosages, we have seen gabapentin have shown improvement in generalized tonic-clonic seizures. Some people promote it for the treatment of neuropathic pain, and now it is indicated for post-herpetic neuralgia when the dosage is very high, more than 1800 milligram. Pregabalin, that is also approved for the treatment of partial seizure without secondary generalization of it, and it is also more potent than gabapentin. The dosage required is quite less than the gabapentin. It has also been approved for use in different conditions, painful neuropathic pain, including painful diabetic peripheral neuropathy or post-herpetic neuralgia, etc. The common adverse effects include drowsiness, dizziness, ataxia, headache, and tremors. Next drug is Tiagabine. It inhibits the GABA uptake. It is also used as an adjunctive treatment for the partial seizure. But as a monotherapy, we have seen it is also quite well tolerated. Its minor adverse effects includes only nervousness, dizziness, tremor, difficulty in concentrating the problem, or feeling of some depression. There may be some excessive confusion and drowsiness, ataxia, but however, all these may disappear after discontinuation of the use of tiagabine. Rarely psychosis and seizure have been observed. Some idiosyncratic reaction involving the skin rashes have also been observed. Topiramate, it is also one of the broad spectrum anti-epileptic drug, which effects are like ferritin and gabapentin, especially repetitive firing of the spinal cord neurons. Its mechanism of action obviously will block the sodium channel. It also potentiates the inhibitory effect of GABA. And thirdly, it also depresses glutamate receptor. So three mechanisms: sodium channel blocking, potentiation of GABA, and depressing the glutamate receptor, which are excited in nature. Its clinical usefulness is in the partial or generalized tonic-clonic seizure. Next is Zonisamide. It is a sulfonamide derivative. Its primary site of action, which is seen, is on the sodium channel, but it can also act on the calcium channels. When given orally, its bioavailability is quite good. It has very little plasma protein binding. It is excreted through kidney, and its half-life is up to 1 to 3 days. The uses of zonisamide are again partial and generalized tonic-clonic seizures, but also useful against infantile spasms and certain types of myoclonus. Its adverse effects only mind drowsiness, some impairment in cognitive activity, and potentially some serious skin rashes also. Now, Rufinamide is a new triazole derivative with very little similarity to other anti-seizure drugs. It has been reserved up till now only in difficult to treat epilepsy with routine anti-epileptic therapies. Now lastly, something about the status epilepticus. Remember, there are three forms of status epilepticus: convulsive status epilepticus, persistent changes in the behavior or mental process, or some focal status epilepticus. Because due to this status epilepticus, there may be some permanent neurological injury, so we should start treatment if this seizure duration is more than 5 minutes for generalized tonic-clonic seizures, or more than 10 minutes for focal seizure with or without impairment of consciousness. Now, treatment. The first choice is the benzodiazepine. We give intravenously either lorazepam or diazepam, or we can give midazolam intramuscularly also. This is the first choice for the treatment of status epilepticus. Second choice is the use of intravenous phosphophenetine or phenetine. We have also tried intravenous use of valproate and levetiracetam and phenobarbital or lacosamide. But if there is a refractory state of status epilepticus, non-responding, then we can increase the doses of phenobarbital at the level of anesthesia. So anesthetic doses of these pentobarbital or propofol or midazolam or thiampental is one of the ultra-short acting barbiturates. Even ketamine have been observed quite effective. And if status epilepticus is super refractory, absolutely not responding to so many management available, we can reinstitute general anesthesia. So this was the strategy of managing status epilepticus. So thank you very much. Inshallah, we will see again for some other important topic. Jazakallah khair. Allah Hafiz.